Let's now do our two case studies for diabetes. We have a case study for diabetes type 1 and another for diabetes type 2. For type 1 diabetes, what do we have? We have a 13-year-old girl, and she was diagnosed with type 1 diabetes when she had been feeling tired, hungry, thirsty, and was constantly eating snacks yet losing weight. Today, she's presenting with vomiting for 1 day and mild diarrhea for 36 hours, and several of her classmates had been recently ill with flu-like stomach symptoms. So, what is the single greatest risk factor for type 1 diabetes that this patient has? And if you review her history, you will find family history, positive family history. An older brother and a maternal grandmother were previously diagnosed with type 1 diabetes mellitus. Notice that also type 2 diabetes mellitus has a very strong genetic component. What caused heavy breathing in this patient? This patient was breathing heavily, deep and fast. Deep and fast. What causes this? This is the result of ketoacidosis. We will know that this patient had diabetic ketoacidosis. Diabetic ketoacidosis means what? Your blood is acidic. Your blood is acidic. And your body wants to compensate for this acidic blood by losing the source of acid, which is carbon dioxide. Carbon dioxide in our bodies is a source of acid. So your body is going to try to hyperventilate, breathe faster and deeper to wash out carbon dioxide, and this type of breathing is an attempt to increase exhalation of carbon dioxide and compensate for acidosis, and it is called Kussmaul's respiration. Kussmaul's respiration. Why is it appropriate to inquire about fever, chills, diarrhea, cough, sore throat, and painful urination? Because patients with diabetes are prone to a variety of infections, and intercurrent illness is the most common precipitating factor for ketoacidosis. So during periods of illness and other types of stress, secretion of catecholamines and cortisol contributes to the development of hyperglycemia and ketoacidosis. Okay, can you identify 3 signs that suggest diabetes, that this patient is dehydrated? Yes. The patient had dry skin with decreased turgor, dry oral mucous membranes, and carotid, femoral, and dorsalis pedis pulses were weak. What are the abnormal lab test results that are consistent with the diagnosis of diabetic ketoacidosis? Well, we have a subnormal plasma bicarbonate, low bicarbonate, and we have elevated anion gap. These are most important characters of DKA. Low bicarbonate, elevated anion gap, high plasma glucose, and acetone concentration. Acetone is a ketone body. These are strongly indicative of ketoacids. But we do not rely on acetone concentration or ketone body concentration to diagnose DKA. To diagnose DKA, you have to have DKA. You have to have diabetic ketoacidosis. Acidosis in a diabetic patient is sufficient to diagnose DKA. How are the anion gap determined in this patient? This is a nice occasion to understand how to calculate the anion gap. Simply, the anion gap is the difference between the positively charged molecules, which are collectively called as cations, and the negatively charged molecules, the anion. So we measure out of the different positive cations, we measure sodium and potassium. So we sum sodium and potassium, and the sodium here in that patient was 127 and the potassium was 6.1, and then we subtract the summation of the negative molecules, the anions, which are bicarbonate 15 and chloride 98, so we get 20.1 anion gap. What's the normal anion gap? Up to 12. So this patient has what? Elevated anion gap. Elevated anion gap is metabolic acidosis. What's the single major precipitating factor for this patient's ketoacidosis? It is infection, and this patient has viral gastroenteritis. How is ketoacidosis most effectively managed? Don't forget, fluids, insulin. Fluids, insulin, and keep an eye on electrolytes.